Okay, start.
Yes, sir. So, good morning, everyone. Today's case presentation is about a 9-month, 10-day-old kid, Master Mohammad Abrar Zayan, hailing from Bangladesh. Informant is mother, whose history is reliable. The mother gave a chief complaint of history of fast breathing at 1 month of age. History of presenting illness. Mother noticed fast breathing with subcostal retraction at 1 month of age. The baby was taken to a local hospital. On further evaluation, was found to have 2 holes in the heart, 2.4 mm AST and 3.4 mm VST, as described by the mother. And then the baby was treated with tab Frulac, 20 mg of Frusemar and 25 mg of spironolactone, 1/3 of a tablet morning and night for the next 3 months. The baby on the next follow-up echo at 5 months showed there was no hole in the heart and there was an abnormality in the great vessel of the heart. The child was further advised to take tablet Indiva 10 milligram, 1/4 of the tablet in the morning and night. The history of forehead sweating while feeding is present. There's history of adequate weight gain, no history of bluish discoloration, no history of hospital admission for recurrent respiratory tract infections. Antenatal history was uneventful. Birth history, G2P1, the code is G2P1, L1, and A1. This baby was born through a
What
lower
does it
segment.
mean?
So,
Mean?
she was conceived twice. The first time there was an abortion 3 years
Okay.
back uh, in less than 12 weeks. This was the second conception. It was the antenatal period was uneventful.
P1 and L1 means what?
So
Para
P1
1.
and para 1 and a live birth 1.
Oh, live. A1 is abortion. Okay.
Abortion.
LSCS. Okay.
Yes, sir. The indication being oligohydramnios. The birth weight of the baby was 3.3 kg. There was no NICU admission. Baby was exclusively breastfed for 6 months. And it's being continued till now. Developmental milestones appropriate for age. Immunization history was appropriate. The baby consumes mixed diet. There's no relevant family history.
Okay, hold on.
Yes, sir.
Go back to your first slide. Now, how do you interpret this history?
So
she was told that she had 2 holes in the heart at 1 month of age, and subsequently at 5 months the holes had disappeared, and then there is some problem with the great vessels. So how do you explain this?
So initially they thought actually initial echo showed 2 holes which was small, but the presentation of the baby was like in failure. So that didn't relate with the septal defect.
So
but anyway,
one there are septal defects. You think she has a left to right shunt according to the history?
No, sir.
No. And baby having tachypnea and baby in failure. What are the common causes of failure in a child, a neonate?
So a significant septal defects.
A significant left to right shunt is one.
Yes, sir.
Okay. What are the other causes of failure in a neonate?
This case specific.
Or an infant. In this case, is 1 month old infant.
Sir, PDA coactation.
PDA is left to right shunt, ma. We have already said that. Severe coact, okay, maybe. It's not very common. All right. Anything else? Remember, this is an acyanotic heart disease.
Yes, sir.
You must think about all the causes of failure in an infant. In a neonate, in an infant, in a child, you must have a ready list and then gradually eliminate one by one by one. Okay, you have a history of a 2.4 mm ASD and 3.4 mm VSD, which was documented.
Yes, sir.
So what happened to that?
On the follow-up, it has closed spontaneously.
It has closed spontaneously. Which are the holes in the heart which close spontaneously?
Sir, actually, I saw her echo report. She showed me the 1 month and 5th month echo.
Hmm.
It was an ostium sagittum AST and a perimembranous VST, sir.
Okay. Because it was small, maybe it has closed. I don't know. 3.4 mm. And ASD 2.4 2 mm is almost like a PFO.
Yes, sir.
It's not. It wouldn't consider it as an ASD. But in a small child, maybe it was big enough. Anyway. So what do you mean by what do they think? What is the other thing? Great vessel. Any problem with the great vessel? What could happen at that age, giving rise to failure?
So that in infant age, the PDA closure.
Come on, Suganya, you are in 5th year, you are going for the exam, you must know these basic things. PDA closure causes failure?
No, sir. Associated with coarctation.
PDA with coact. Okay, you probably already know your diagnosis, that's why you are going on harping on that. Okay. What other things could be there? Could she have an AP window which was?
Yes, sir. Or arch hypoplasia.
Okay, what did you find in your examination?
No, just wait. What are the important signs, symptoms and signs of left heart failure in a newborn?
We said this last class.
Yeah.
And you already forgot it.
Every student says forehead sweating, you know. That's the last thing, you know. The symptoms are tachypnea, tachycardia. And the most important thing to have is a feeding difficulty. That's what the mother, because normally child sucks, you know, it needs a lot of energy and produces heart failure. So that means the child cannot continuously feed. It's feeds, stop, and then feed. So you can say suck, feed, cycle, or, but the most important classical thing is generally known as feeding difficulty, failure to thrive. These are the things you mentioned. Then you say forehead sweating, but that's not the most important sign of a left heart failure. All these kids with a very large left to right side present with a left heart failure, volume overload, the left atrium, left ventricular failure. So that should say not feeding, not just forehead sweating, you know, tachypnea, tachycardia, and then feeding difficulties, failure to thrive. In that left heart failure, of course, forehead sweating also can be, but that comes last. So that's one thing. The other thing, what are the types of presentations of coarctation of the aorta?
It is a bimodal presentation.
Good. What is bimodal?
One presentation happens in the first week of life, first group.
Very good. That is what previously people used to call preductal coarctation
or infantile.
But nowadays, that is not mentioned very much. Most of the coarctations are juxtaductal. Even if it's a juxtaductal, when the PDA tries to close, we discussed last time the physiological and anatomical closure of the PDA. Because in such a in such a coarctation, only source of blood supply to the lower limbs is the ductus. So when the ductus closes, what happens when the ductus closes? There's no circulation to the lower part of the body.
Then baby will present with shock, cardiovascular shock.
Shock syndrome, anuria, oliguria,
renal failure and acidosis.
Acidosis. Yeah.
That's a type
visceral
of
acidosis.
That's a type of presentation. Severe shock, acidosis, lactic acid increase, and then that's a type of presentation in an infant. Then after that, they may present later on. In some cases, there's signs of left heart failure. But if they don't present at that stage, they may be asymptomatic up to the year of 14 or 15. Then they started symptoms of hypertension. And ischemia of the lower part of the body, and get claudication and things like that. So this is a type of presentation. So the first presentation, as soon as the ductus closes, the whole circulation to the lower part of the body is cut off, and they present immediately, and that needs immediate surgery.
Yes, sir.
That is later presentation. So this you should be sure. Okay. So actually, first examination, they miss the coarctation. That's what it is.
Yes, sir.
Why do they sometimes miss the coarctation? In echo?
So subjective, and once they, I think, when they found the septal defects, they just diagnosed it. But I think the baby presented because of coarctation.
We mentioned suprasternal view has to be taken to see the shelf of coarctation. The high upper parasternal longitudinal axis view, and most important, suprasternal view of the echo is taken to see the coarctation.
We discussed this last class, just last class.
Okay, all right. Now we can proceed.
Yes, sir. On a general physical examination, the child is conscious, playful, cooperative, and afebrile. No pala, no not icteric, no cyanosis, no clubbing, no pedal edema, or no generalized lymphadenopathy. Vitals, the pulse rate is 117 per minute, regular rhythm, normal in volume, no radio-radial delay. Radiofemoral delay is present. All peripheral pulses are palpable, but the lower limb pulses are feeble. The blood pressure is 98 by 52 millimeter of mercury measured in right upper limb. Lower limb blood pressure is not recordable. The respiratory rate is 32 per minute, abdominothoracic type of respiration. Saturation is 97% at room air. The JVP is not raised.
When do they present with a differential cyanosis? What exactly do you mean by differential cyanosis?
When associated
if you have, I don't know if you have read Tendulkar's books, very often in neonatal coarctation, because the ductus closer, they present with cyanosis of the lower limbs, and he has also described in some reverse cyanosis of the upper part of the body in some transportation great vessels. That's all. You read it up and see. Okay. So differential diagnosis of this can be there. But the exception is that even in neonatal coarctation with a ductus, there may not be differential diagnosis if the large VSD. Because if there's a large VSD, the shunt from the left ventricle to the right ventricle and to the ductus arteriosus, so much so the saturation in the lower limb may not come below 85, So that you have to be a saturation of below 85 to appreciate cyanosis. So differential cyanosis and the exceptions for that, and the reverse of that, upper part of the body blue and the lower part pink. So read about these things and okay.
Yes, sir.
These are all classic Viva questions sir is asking you.
Yes, sir.
Write down these questions, find answers, and keep a ready reckoner. We can't be telling this every time. You have to make notes when you're sitting in this classes. Otherwise, you will forget it by the time the evening when you have dinner. By the time you have dinner today, everything is forgotten. So differential cyanosis is a classic Viva question.
Okay.
Okay.
Yes, sir. Cardiovascular system. On inspection, apical impulse is not seen. There are no scars, engorged vein, chest deformity, or pulsation or
What about-
recording with chest.
Did you take blood pressure in all the 4 limbs?
Yes, sir.
She couldn't get on the lower
Okay.
limbs.
Upper limb, I was able to record. Lower limb, no, sir.
Able to record the upper limb. Lower
Yes,
limb
sir.
is difficult one to have. What the
Yes, sir.
importance recording the blood pressure in all the 4 limbs?
To appreciate a gradient.
Yeah, you can appreciate roughly the gradient. Of course, you got echo and other things to confirm it. What else? Suppose the left arm pulse is and the blood pressure is lower.
So it will tell us the site of coarctation.
Very good. What site is it?
If the left side is lower, then the coarctation is proximal to the left subclavian artery.
Yeah, coarctation proximal. Or coarctation.
I mean the constriction.
Yeah, pre-subclavian.
Yeah.
Then
Hypoplastic, distal hypoplastic.
Hypoplasia, the coarctation extending to almost the origin of the subclavian artery. Suppose the right arm blood pressure is lower.
Then maybe the right subclavian is abnormally originating from the DTA.
Yeah. Don't say abnormal. Aberrant.
Anomalous origin from the DTA.
Not anomalous. Aberrant subclavian. That's what the classical term is,
Okay.
Subclavian which arises after the arch of the aorta, below the ductus, and then crossing, and that's what produces all the signs of,
Yes,
of indentation of the esophagus and other things. Esophagia, lusoria, they used to say, where the aberrant subclavian.
Mm-hmm. Yes.
So, proceed. I don't want to stop you.
On palpation, apical impulse is felt to be in left sixth intercostal space, half-inch lateral to mid-clavicular line. Normal in character. No palpable heart sound or parasternal heave. No palpable pulsation noted over the chest. On auscultation, S1, S2 is normal. A systolic murmur of grade 3/6 is heard in the left infrascapular and interscapular area. No other murmurs are heard.
What are the murmur you look for?
So, incorporation, the murmurs are associated with the intercostal or the murmurs in the apex associated bicuspid valve.
Most important, aortic. Because
Bicuspid aortic valve.
85% of the 80 to 85% of the patient with coarctation may have a aortic valve stenosis also. Okay.
Yes.
Then bicuspid aortic valve is the most common. Bicuspid.
What is that complex called?
So Schoen complex.
Combination of aortic stenosis, valvar, supravalvar, and then coarct.
Schoen complex.
Yeah.
Then look for a VSD murmur.
Yes.
What's the percentage of association of coarctation with VSD?
%25.
Yeah. Some people say 18 to 25%, some people say 11%. 18 to 25, if you say, I think it's okay. Right.
Okay, sir.
18 is
On other system examination.
One sec. When you go back to your previous slide, what do you think that murmur is due to?
So that murmur is due to coactation.
Coarctation only. Supposing, what other things murmur will you hear in that area? We discussed this last time.
So collaterals.
Collaterals. When do collaterals come about?
After 4 years of age.
Yeah, when the child is over much more this thing, and when the child has more activity. It's very rare within the first year. Okay.
Yes, sir.
Yeah.
Other system examinations are normal. Respiratory system, bilateral normal vesicular breath sounds here. No added sound. Per abdomen is soft, not tender, no organomegaly. Central nervous system, higher motor function and sensory system is normal. No focal neurological deficit. Provisional diagnosis is acyanotic congenital heart disease, a coarctation of aorta, postductal in sinus rhythm, with past signs of failure on treatment, with no signs of pulmonary arterial hypertension, thromboembolism, or infective endocarditis.
When you talked about the history, now
Yes, sir.
It appears that you were biased already because you knew the diagnosis. So when you talked about the history initially, you talked about signs and symptoms of a left to right shunt, which was closed, which probably closed. You know, AST and VST is closed.
Mm-hmm.
Might have closed. So if you don't go directly to coarctation, you should think about other left to right shunts that can happen, and then come to coact as a later diagnosis. If you straight away go AST and VST is closed, and then you got coact, that means you know the diagnosis. Okay. So you have to build up your diagnosis gradually, and then take the examiner in that direction. So you must bring in AP window and other left to right shunts at the great arterial level before going on to coarctation, because coarctation presenting as failure is in the very early stage. This patient, this child is 9 years old. I mean 9 months old.
Yes, sir.
So it's unusual. Okay. So as Jairaj sir said, they present in the early first week with severe cardiogenic shock, and then acidosis and tachypnea and all other signs of failure. So when you discuss about this thing, don't bring in the diagnosis of coarctation straight away. Sir, the other possibilities could be this. I will like to examine and then find out from the examination point of view. Then you come to that, because in your examination finding also, you can't make a clinical diagnosis of coarctation. You follow?
Yes.
Your blood pressure reading and then this thing was not very clear, and just this thing in the systolic murmur. Yeah, maybe you heard this in the back, so maybe that could be a part of it. But otherwise, by clinically, it is difficult to say this patient had coarctation with the given history.
In this stage, will you expect a brachiofemoral delay?
At this point of time, sir?
No, one of the classical signs, if a 10-year-old child or a bigger child comes, one of the signs is a brachiofemoral delay. You know? In this 10 month.
So yes, sir, delay was there.
You didn't highlight that.
Very often delay appears only when good
I told you.
collaterals have appeared, and there's no forward flow through the coarctation. That's when actually the brachiofemoral delay appears.
Yes, sir. This patient had a delay.
Okay.
So is it possible that, theoretically, because of the coarctation, baby initially went into failure, and since the baby was in treatment, no further symptoms appear?
Yeah. That particular failure is treated by, the diuretics, and in this case, it's a lacilactone or something is put. Sometimes they used to put digoxin also, which they don't do, and sometimes they put ACE inhibitors.
This child was initially on furosemide as a diuretic, then subsequently changed over to what? Metoprolol.
Yeah, propranolol. Propranolol, sir.
Propranolol. Is that a normal drug for coarctation? I'm not sure.
Treated in Bangladesh, sir.
No, it's only given when there's proximal hypertension. Otherwise, you don't use the beta blockers for failure, actually.
Beta blockers are not the general drug for alveolar obstruction. Should not be done.
When severe hypertension, they use it.
Yes, sir.
And the proximal hypertension doesn't occur at this age, it's usually slightly later. Okay. So,
yes, sir.
So what do you think? This patient, you said it's a bimodal presentation. The neonatal, you have to do surgery immediately. Sometimes you can delay surgery. What do you think in this case? You want to investigate immediately? You want
Yes,
to
sir.
the surgeon? Yeah. Why? Obviously,
Why do you want to treat this patient?
Yeah.
So, coarctation should be treated, diagnosed.
All coarctations need not be treated immediately. What a classical teaching in our hospital for surgery, timing of surgery of coarctation.
Severe coarctation, they advise immediate surgery, sir.
Neonatal coarctation with all this failure, acidosis,
that stabilize initially to stabilize.
That surgery.
And then take on a semi-elective basis.
Then after that?
Stabilize the baby and then take on a semi-elective basis, sir. Adults, they advise surgery.
No. When do you? What sir is asking is, what is the timing of surgery in a normal coarct?
So if the baby presents with shock, initially
there's no question. Patient with a shock, immediate surgery.
You said that already.
It already said, because you have to give soda bag, carb, and other things, or all sorts of things. Sometimes you may have to give iron drops. All those things are understood.
If the baby is asymptomatic and it is found, then we can wait up to 1 year, let the baby grow, and then we can.
Not exactly. Previously, we used to say asymptomatic patients, no proximal hypertension, you can wait for 3 to 4 years. But that's changed now. Why have they changed those things? Why do they think that it has to be done early rather than late? What happens if you operate on a case later? And the classical teaching we used to say is that before school going age, 4 to 5. But now the Narayana Hridaya is a child coming with coarctation. Even there is a mild proximal hypertension, the age of correction is 1 year. Of course, there are not advanced centers. But if they are presenting without proximal hypertension, and in this hospital, it's operated about 2 years and or 3 years or 2 or 3 years. The problem is that if you operate less than 3 months, because neonatal is what are the complications of doing that? Doing it 3 to 6 months? The recurrence
Recurrent coarctation issues.
very high actually. So you wait. So in this hospital, usually no proximal hypertension. You can wait up to 2 years. This proximal hypertension, 1 year is a classical time. Then what's your idea of doing a catheter orthoplasty and surgery? At what age will you select that?
The balloon dilatation.
You address balloon dilatation.
Is it recommended? At what age?
No, sir.
Why not?
High chance of recurrence.
Yeah.
And also the femoral artery complications are much more. So 100 times I tell you to read that recommendations. They say below 6 months, don't try to do catheter, coarctoplasty and other things. Surgery is better. But only exception in that paper said, which I don't know if it's correct or not, in a neonatal coarctation in shock, you can do coarctation plasty by catheter, but I'm not so sure. It's better to treat the failure, treat all those acidosis and do surgery. That's the best thing. So below 6 months, it's not a good thing to do.
In my objection to that, sir, is in shock the peripheral vessels are even more smaller, and the catheter access is going to be a problem, and then they will create more problems to the distal circulation and limb ischemia. So it is not a good option even if there is a shock.
So in examination, you should answer that as a surgeon. The first indication, the first treatment is surgical correction. The catheter dilatation is required only in recoarctation. For 2 reasons. One, recoarctation, the surgery becomes more difficult, and in them, the catheter dilatation successful. So as a surgeon, you should say first is surgical correction. Recoarctation can do better. I think that should definitely, that's what my opinion as a surgeon. I don't know, Krishna agrees with that.
Yes, sir. The catheter dilatation is only for recoarct.
Okay, all right. Then now decide the time. Now you have to decide on the type of surgery.
Yes, sir. Confirming the diagnosis.
You have finished the echocardiogram if you find it? No.
No, sir. No, sir.
X-ray, ECG, X-ray, and
yes, sir. So this is an ECG with a limb lead ECG alone, which shows a normal rate, sinus rhythm, normal axis.
Don't say normal axis. Please get into the habit of telling the axis by so many degrees, because that is important as a prognostic tool. Normal axis does not mean anything to anybody. It could be anywhere between -30 to 90 degrees. Okay?
Okay, sir.
So always, whenever you read an ECG, whenever you do this thing, measure the axis. Measure the axis so that it can be used as a prognostic tool, a simple prognostic tool in the post-operative period. Whether the heart is recovering, whether the heart is improving or it is deteriorating.
Okay, sir. It is only limb leads, chest leads are not available.
Okay.
Yes, sir. The chest X-ray, AP view, slightly rotated. The trachea is in midline. The mediastinal widening is noted.
After the rotation, you decide only also by the trachea, the midline or not.
Yes, sir.
Trachea overlapping the spine and the spinous process in the midline says that it may be an okay X-ray. All right.
Okay, sir.
The position of the clavicle is secondary.
Okay, okay, sir.
These are fixed elements, the spine and the trachea. Okay.
Yes, sir. Cardiomegaly present. Lung fields are normal. Lung parenchymal fields are normal. CP angle clear.
Is this X-ray collaborative of your diagnosis? Is it a classic co-opt X-ray?
Not only cardiomegaly is seen.
Cardiomegaly is a common thing in just this thing?
It's not actually. Yeah.
And under the classical signs are not seen.
Cardiomegaly does not come unless there is an associated VSD or something. Because
either VSD or a bicuspid aortic valve with regurgitation also. Otherwise, they don't produce cardiomegaly, usually co-opted. Because it's a concentric left heart hypertrophy, because of the
and there is an RV type of apex. The apex is upturned, which is not a classical feature of co-opt. Right? So,
yes, sir.
So this X-ray is equivocal or not corroborative of your diagnosis. Anyway, it happens. So you have to go for an echo. And echo, yes. What all are you looking for?
Measure, there's no plethora also, because may be associated with VSD.
VSD or not, yes, sir.
Okay.
Echocard. Yes, sir. Echocardiography.
Yeah.
Levocardia, severe post-subclavian coarctation of aorta. The aorta as such normal. The arch is left arch. The transverse arch is 7 mm. Juxtaductal arch, there is a narrow segment measuring 2.8 mm. The long segment coarctation. The gradient is 53 mm of mercury with a diastolic spillage. Other than that, there is a bicuspid aortic valve, no aortic stenosis or aortic regurgitation.
Very good.
There is no mitral stenosis. The mitral annulus is 14, and the mitral inflow gradient is 9/6 mm of mercury. No mitral regurgitation noted. Good biventricular function. And the septa, the interatrial and the interventricular septum is intact. No pulmonary arterial hypertension, and the branch PAs are confluent.
The complete echo gives you all the information you want or not?
Yes, sir.
What is ascending aorta diameter?
That is not clear.
Bicuspid aortic valve, ascending aorta diameter should be there, no?
Yes, sir. It's there, aortic sir. 14 mm.
Huh?
It's there, sir. Aortic valve annulus is 11 mm. The sinus is 13. Yeah, sir. Here, the sinus is 13. The sinotubular junction 10 mm. Ascending aorta is 14 mm.
The most important thing in coarctation is to find out what the diameter of the ascending aorta. This I'm saying without aortic stenosis or bicuspid valve listen without stenosis will not produce any proximal diameter. The most important thing to find out is what's the proximal arch, what is the measurement of the ascending aorta, what's the measurement of the arch between the innominate and the
Yes, sir.
left subclavian, and
Yes.
what is the distance between the left subclavian, the left carotid and the left subclavian, and what is the isthmus diameter just after the left subclavian.
Subclavian and the insertion of ductus.
The importance is that very often coarctation is associated with a arch hyperplasia. And the definition of arch hyperplasia. And
the proximal and distal arch is less than 60% of the diameter of ascending aorta.
Yeah, very good. You know that. But you, then if there's a hyperplasia of the distal arch, you have to verify your operation to do extended coarctation and a distal arch plasty. Okay, so that's the importance of measuring the ascending aorta, the proximal, and the mid and the distal aorta. All those measurements you require.
Yes, sir.
Now what? So this is enough for you to decide on surgery?
Yes, sir. The transverse arch is 7 mm.
Yeah.
The ascending aorta is 14 mm. So better to get a CT scan to rule out the arch hyperplasia also.
Very good. Because echo alone will not give you the exact measurement. So very good answer. And CT is much better. MRI may be better, but in a baby like you, nobody will try to do MRI, because it needs anesthesia and other things. So CT is the best thing. Okay, good.
Got a CT scan done yesterday.
I think for measurements, CT is better because it's a still film. MRI is usually meant for functional assessment, and for measurements, CT is better.
Yes, sir. Other thing is abdominal aortic tracing is non-pulsatile.
Gradient of 58, is it?
Yes, sir, 58 millimeter mercury. So this CT scan.
What's the definition of coarctation or recoarctation? Usually it's more than 20 millimeter recoarctation. Also, the diameter becomes less than 50%. That's a usual definition. And this
more than 20 millimeters the length of recoarctation segment.
Okay.
No, the gradient. That's talking about the gradient.
That's
okay. Millimeter of mercury. No.
So there's a significant coarctation, you said, and the coarct is 2.8 millimeter, is it?
Yes, sir, in echo.
This needs surgery, and I think it has to be done immediately because child is also on failure. So no point in waiting, you have to do surgery.
What is the best operation for coarctation?
So at this age?
No, I'm just asking you a general question. What is the best operation for coarctation?
So resection and extended end-to-end anastomosis.
Why extended? Resection and end-to-end anastomosis. That is the classic operation. What are the other things that you could do? I mean, what are the other methods of treating coarctation?
Prosthetic patch iotoplasty.
Never.
Or prosthetic interposition graft.
Never. That is the last thing to say.
Prosthetic interposition graft.
No.
Yeah, that is all. What is the next thing that you do in a child?
Please don't mention interposition graft in a small child.
No, not in a small child.
This is a 10-month-old. An interposition graft or a dilatation with a stent can be done only when the aortic diameter is bigger. So classically, the Indian Association says more than 25 kilograms or more than 10 years of age. You don't put an graft, interposition graft. You don't put a stent at that age, The cutoff in that, they say 10 years or 25 kilogram patient. Below that, you don't put a stent, you don't put a interposition graft at all. You didn't mention the number two. First is
resection of extended anastomosis or subclavian flap.
Waldhausen repair. The second one is Waldhausen repair. The third one is extended aortoplasty onto the transverse arch. These are the classical ones that are done, and then you go on to interposition graft, and then this thing that is usually in adults. Okay.
Adult patients.
In small children, now you have end-to-end anastomosis, you have Waldhausen, and you have a transverse aortoplasty. In this patient, what are you going to do?
It's a resection with the end-to-end anastomosis.
Is that easy to do in this patient? Somebody mute your phone. Somebody mute your phone.
Karan,
mute your phone. So in this patient, you think end-to-end anastomosis is easy? Suganya?
Yes, sir. Yes, sir.
Is it easy? You got a long segment coarctation. That's what they have said in echo. In a 9-month-old child, it is more than 2.8 millimeter long. That means almost 1 inch long. So you have to do extensive mobilization.
Yes.
Yeah. And your transverse aortic diameter is small.
Yes, sir.
So end-to-end anastomosis is a good option in this patient?
No, sir. Extended or a subclavian flap aortoplasty.
So you straight away said end-to-end anastomosis. No, this is how you get into trouble in the examination. You must think what are your investigation showing, and what operation you're going to decide.
Yes, sir. Yes, sir.
Huh? What are the pros and cons of Waldhausen repair?
Advantages is it is easier to do, short cross clamp time, prosthetic material is avoided, and increase the anastomotic growth because of the autogenous tissue. Disadvantages in older children we can't do because of limb ischemia.
Please don't say prosthetic material is avoided. We never use prosthetic material at this age, That's okay. The only thing is you're taking off left subclavian, so there may be some problem. But that still people do in a small child. It can be done. There may be reduced growth of that
long-term growth and function of left upper limb.
And also, suppose the vertebral artery is in situ, what can happen? Because when you do a subclavian, you take off the subclavian. Suppose you take the subclavian below the vertebral artery.
It may cause a steel system.
Huh?
As a child grows, it may cause subclavian steel.
Yeah, subclavian steel. You know what it is?
Yes, sir.
What it is?
So when actually we might leave it to provide collateral circulation, but when the child grows, the perfusion to the DTA increases than to the cerebral circulation.
I don't understand that. classical simple. When you exercise the left hand, because the vertebral is there, it steals circulation from the circle of visage through the vertebral to the left hand, that's what is a steal syndrome.
Mm.
So the thing is, you're using native tissue, you'll allow for growth in as the child grows. And the only thing is that the problem is sometimes there may be differential growth of the upper limb, and also may involve the vertebral artery. So Waldhausen, these are the pros and cons. And then in this patient, you have some sort of transverse arch hypoplasia. So you may have to do an extended slide iotoplasty. Okay.
Yes, sir.
So
Okay, sir.
on table, we still agree with you. On table, you can see if you can dissect and mobilize the aorta so that you can do an end-to-end anastomosis without tension. This is possible in small children. If it is okay, then you can still go ahead and do that. And if not, you may have to do a slide aortoplasty.
Yes, sir.
Okay, that you better check with your pediatric consultants and see what is the best option. Like that, in the exam, if they ask me, what should I say?
Yes, sir.
And when you are doing an end-to-end anastomosis in a child, what are the suture material, and then what are the suture technique that you're going to use?
So continuous polypropylene suture.
Very good, excellent. So that it is 2 millimeter now, and as the child grows, it stays at 2 millimeters and causes recoarctation. Is that the standard teaching? It can be done because you want to do a quick fix at the time of surgery, but what is the long-term effects? Classically, it was taught that the posterior layer is done continuous and the anterior layer is done interrupted, so that it can allow the coarctate segment to grow along with the child. I'm not sure whether they follow that now.
No, they do continuous sutures.
What do you say, sir?
Yeah. And what about, do they use polypropylene or PDA sutures? What is
no, so polypropylene. 7 or 8 to.
Okay, but then how do you manage the growth? If you're using continuous suture, what happens to that segment as the child grows? It's okay, you have done an immediate cork repair and then quick fix done, just like the cardiologists do this thing. And subsequently, long-term effect, what happens? Patient will come back for recork. So these are things that is to be kept in mind. Will you please check with your consultants, yes, because they don't seem to find it useful to come to these classes? Please get these answers sorted out with them. And, yes, and what are the objections that we have asked for? How do they manage that? If you use continuous Prolene sutures, what happens to the growth?
Yes,
okay.
Yes, sir. Whatever I've seen, it was all a grown-up children.
Yes,
where they use continuous.
Agreed. You have seen
this
that.
Kid, I will. Yes, this kid is Shekhar House's patient. I consult with
find out how do they manage, what do they manage, or do they think that it is not important, and why do they think it is not important, and things like that. Okay.
Yes, sir. I'll let you know next class.
All right. Now,
why do you say the resection into anastomosis is a very good operation?
So, because
to know that, you should know the etiology of coarctation. What are theories of etiology of coarctation?
Sir, flow theory and ductal string theory.
Yeah. First is the ductus theory. Yeah. What is the ductus? What is the structure of a ductus?
So that if there's an abnormal extension of that contractile ductal tissue into the aorta.
Shelf lighting. Yeah.
Yes, sir.
Actually, ductus has got a endothelium, adventitia, and 2 layers of muscular muscle, and longitudinal inside and circular outside. This is the structure of the ductus. In a normal individual, the ductal tissue extends not more than 1/3 of the diameter of the aorta onto the aorta at the ductal end. In a coarctation, it extends usually circumferentially. So when they contract, it produces severe coarctation. The other theory is hemodynamic. When there's a relative flow between the pulmonary artery and the aorta, if the aortic flow is less, the development of aorta is less, and that is the flow or hemodynamic theory. That's why we often, in a tetralogy of Fallot, where the pulmonary flow is very little, and most of the flow is to the aorta, coarctation is rare or almost nil. So that is
in the right-sided lesion.
These are the two theories. So when you do end-to-end resection, you are removing all the ductal tissues, and that is the same explanation for what you first said. Patch aortoplasty with Dacron. That's the worst thing given up long time ago. Why have they given up that? It's the easiest operation. You don't have to sacrifice any collateral. Very easy to do. We all used to do it one stage. Very easy. Only thing, you have to measure the size of the patch, the diamond shaped patch. But why it has been given up?
Aneurysm formation.
Where?
The posterior aortic wall, opposite to the patch.
Opposite. Good. Very good. Okay, that's why it's given.
Why does that happen to the opposite the patch?
The native aorta start dilating.
Why?
Because the prosthetic material remains the same. As the child grows, the other part of the aorta starts enlarging, and due to the
no, it is prosthetic aorta. Prosthetic patch is a rigid structure, and the native aorta is pulsatile, so it starts dilating, distending.
Yes.
So that causes the aneurysm.
So the whole flow coming from the arch hits the rigid patch and it's reflected back. So all the pressure effect is on the medial side where the ductal tissue is still present and the aneurysm formation. So that's why they're given up.
Yes.
You know all the steps of surgery also, I'm sure you must have.
Yes, sir.
What are the steps of surgery for an extended archplasty for distal arch hypoplasia? Is it an end-to-side or end-to-end anastomosis? So you must have seen the pictures in all the books, is a Mayung Park or any other thing.
You should read about this, okay?
Normally, when you do a resection anastomosis, you transversely cut both ends and then anastomose it. In an extended part, you
the
cannot.
Inferior surface of the arch will go, and in the same way, like a mirror section, will cut across the DT.
Very good, very good. So what you do is actually beyond the left subclavian, you cut the aorta and suture it, and then underneath the aortic arch, you make an incision and you mobilize the descending aorta and make anastomosis end of the descending aorta to the side of the aortic arch. For that, you have to put a side clamp. including the left subclavian, left common carotid, almost up to the innominate. Then only you can do extended aortic velocity. Then the whole circulation for the brain comes from the innominate. So you should not include the innominated clamp, but you include the left subclavian and the left common carotid. And under the arch, you make a transverse incision and you make a end to side anastomosis. That's a extended aortoplasty. Okay.
Yes. Why innominate? We should not include.
You need some flow going to the brain, madam.
Okay. For clamp. Yes.
Fine. You are doing on a beating heart. If you do
beating heart,
other type of coarctation, both from midline and VSD, as well as coarctation from the midline on bypass, it's different. But here you can't,
Yeah. Okay. Yeah.
Supposing you have a VSD along with coact, what is your sequence of operation?
That's a classical question all examiners ask. Combination of these two. Don't hesitate too much. That's a simple answer. Fast.
Are you there? Sukanya, are you there?
Connected. Any other binary student?
Anybody else can answer this question? Why is Amulya not attending these classes? Is exam going? I thought only location.
Sir, can you hear me?
Yeah, now we can hear you. Tell me.
Yes.
You quickly Googled it, I think.
No, sir, it got disconnected.
Okay. We
trust got a call, so it got disconnected.
All right.
Yes, sir. So what's the question, sir?
Question kya hai? Okay. If you have a combination of VSD and coact, how will you plan your operative sequence?
So
we disconnected again.
So because call is coming. So now you are able to hear?
Yeah, you can hear.
Yes, a coact tripper followed by VSD closure.
Why is that?
So if you correct the coactation, once you put the baby on a bypass, cardiopulmonary bypass, the distal perfusion is preserved.
That's not the answer.
And relieve the distal obstruction first.
That's also not the answer. You should specify very significant coarctation with a mild to moderate VSD. The classical approach is from the left side, do the coarctation surgery and wait. They say if in the next 1 or 2 weeks, sometimes you may have to go and do the VSD again. The other thing they used to say is that significant coarctation with a large VSD, you do a coarctation repair from the left side and do a pulmonary artery banding. That has been given up now. It is done only when there's a Swiss type of VSD or very large VSD, which is equal to a single. We have described those conditions where pulmonary artery banding. So that's also given up now.
Yes.
There are two methods nowadays. All the recent cardiac surgeons do both from the median sternotomy on cardiopulmonary bypass can be done. But the argument for doing a mild to moderate VSD with significant coarctation, do coarctation and wait. Some of them may close also, So they don't close if the child is difficulty. You can do the other thing, operation anytime. And previously, Colin John used to do the coarctation on the left side of bypass and turn the side. That many people don't do. They wait in the post-operative period and see how the child behaves, can be easily taken out of the ventilator or not. Then do the later. So that's the plan. Significant coarctation, might do the coarctation alone.
Okay, sir.
Modern day good cardiac surgeons can do both very large VSD, significant coarctation. They can do both on the midline. The only problem is that on the midline, classically in Krishna we were operating, to do an end-to-end anastomosis, you have to mobilize the descending thoracic aorta only, even up to the diaphragm to get a good length without any tension on the suture. That's difficult as far as I know from the midline. But otherwise, that's what is the practice now.
Yes.
Okay.
Some of these controversial things and things that have changed over the years, you have to check with your consultants, the present day people, how they do, and then you have to say that. Okay.
Okay, sir.
These are questions that you have to find your answers from your consultants.
What are the complications of coarctation surgery? And during procedure, what do you do with the ductus and other things during a coarctation surgery? What's your approach for the coarctation surgery?
Sir, this will be left posterolateral thoracotomy.
Then thoracotomy is done through which space? Sir. Through which space?
So, third space, sir. Third intercostal space.
Usually we go about to the fourth space.
Third or fourth space.
Yeah.
You have to mobilize the descending aorta as well. It's not a PDA. So even for a PDA, the usual classical teaching was the fourth space, so that you dissect the mediastinal pleura up to the subclavian artery above, and then down below, and then you isolate the coarctate segment and then do that. And again, like last time we said, you have to loop the aorta above and below.
Aorta proximal and distal.
So that you have enough space for clamping. Now, how long can you clamp? We said this last time.
So 30 minutes.
30 minutes, yeah. So you have to.
Last time we said in a normal, without coarctation, 20 minutes. But there's good collaterals, you can clamp more time.
To 40 minutes.
They not exactly actually. You clamp above and below, and then you see the distal aorta, whether it is bulging or pressure. If it is collapsing, it's dangerous. Otherwise, it's not dangerous. You can clamp for a long time. The most important thing, what you do with the ductus, because it needs absolute mobilization. The subclavian artery, the part of the arch, and the coarctation part and below. So what you do?
So the ductal tissue, the entire ductal tissue inside the coax segment is resected.
Not resected. Why resect?
No, the tissue inside the coax segment is resected. But if PDA is present, we do ligate and divide it.
Never do that. That's the easiest way for that to slip and disastrous hemorrhage. You have to divide and suture both ends, or
Yes,
the
sir.
aortic and then the pulmonary.
Over to them. Yes, sir.
Don't say ligate and divide. That's a disaster.
Okay,
The
okay.
most important thing there may be arteries arising behind the coarctation. That's how complete mobilization of the coarctation segment above the left subclavian part of the distal arch, everything is mobilized, and make absolutely sure there's no branch joining on the posterior part of the coarctation. Otherwise, you clamp above and you clamp below and you open, you're in great danger. All the blood is coming from an artery which you have missed.
Mm-hmm.
How do you avoid that? Sri Krishna used to tell you always.
Once you clamp above and below, and if the segment of the aorta is still bulging, you have to aspirate that area and make sure that it collapses. If it doesn't collapses and it refills, that means there is an artery supplying from the posterior wall.
Yes,
So
sir.
you have to take care of that. Otherwise, you will have torrential bleeding in your field. Yeah.
Yeah.
That
Yes,
is
sir.
that is one practical step you should never forget.
Okay.
And then only once, that means you have isolated that segment completely, it is avascular, and then you can excise that segment and then do an end-to-end anastomosis. That is
Yes.
something. Sometimes in an adult, it is very difficult to mobilize the aorta from the posterior mediastinum. So in such a case, you may have to sacrifice one or two intercostal vessels
Okay, okay, sir.
on both sides. Then only you can mobilize the aorta. So end-to-end anastomosis in an adult is difficult. Okay, and
Yes, sir.
it's extremely difficult if it's a long segment coarc.
Mm.
Then the other thing that you should know is declamping shock. What is declamping shock?
Mm.
Anybody? What happens when you clamp the aorta to the distal segment?
Circulation to the segment.
And what happens when you
So after clamping initially the mean distal pressure increases by 5 millimeter of mercury
increases?
after 10 minutes.
How? Why?
It's something new.
No,
You're a little confused, I can see. Declamping shock is very important when you're doing coarct repair, when you're doing descending thoracic aneurysm repair. All right. Because if you suddenly open the clamp, then there is severe hypotension, and then there is it leads to low cardiac output. So you always release the clamp gradually, one to two at a time. It's a long clamp, isn't it? So slowly,
one ratchets.
and tell your anesthetist that he should be ready with soda bicarb and other things to make sure that there is no acidosis in the distal perfusion, in the visceral perfusion, and then gradually remove one at a time, one rung at a time, so that you take about 4 to 5 minutes before you completely release the clamp.
Okay.
Declamping shock is a very important thing. You'll have a sudden crash of the patient if you just unclamp the aorta. Okay.
Okay, sir.
Because of the ischemic lower part of the body, the lactic acid metabolism and all the lactic acid thing returns to the heart. Usually, heart even fibrillates at that stage. That's why you have to tell the anesthetist to be prepared with those, how to manage the pressure, and if that's not, then otherwise you clamp it again, because then the anesthetics take the measures to avoid hypotension and the heart fibrillates at that stage. That's the most on the table.
So it's
Then
an
the other thing,
important step both in descending thoracic aneurysm repair as well.
Yes, sir.
you always release the distal clamp first. Then you can see your anastomosis, it fills up, bleeding or not. Then only you slowly try to release the proximal clamp, and be prepared to clamp it again if necessary. Then because the anesthetist can take all the measures to avoid hypotension and ventricular fibrillation. So that you should know. The other thing, post-operative complications of coact. That's a important question all examiners ask you. What are the post-operative complications of the coarctate? At the time of surgery, post-operatively.
At the time of surgery, bleeding, tension at the anastomotic site.
Very good. Bleeding, yeah. Recurrent nerve injury. And later on, chirothorax. These are the operative complications. The post-operative period, what are the complications?
Paraplegias.
Huh?
Yeah, that can happen.
Don't say that. Don't say that. First thing.
Okay.
First thing that happens, what happens to the hypertension?
Yeah. You decide, the examiner should not be extracting these things. First thing is a paradoxical hypertension. Then they will ask you what are the types, what are the causes. We have described this so many times. Nobody listens or nobody attends classes.
They don't make notes. They don't look back again.
You go and refer Tendulkar's book.